Ladies and gentlemen, hello. Good afternoon. Thanks for EUROSPINE for selecting us, and thanks for my co-author for this very long work that started more than 20 years ago. So most important is to understand if there is a real long-term data about the total disc replacement we use for more than 30 years now. This study concerns 1,187 patients, 1 and 2 levels, and we wanted to debunk some ideas. And first, is the 1 level or 2 levels equivalent? The second point was, is there an indication for total disc replacement after prior surgery, discectomy, when there is a recurrent disc herniation or a post-discectomy syndrome? After that, you can see also that after 20 years, in this professional dancing girl, there is a great motion, and a great motion 20 years after like that proves that there is no fusion and no loss of motion at the index level and above and below. What is important is that we publish long-term for our studies in 2004, and now 20 years after, we republish new long-term with an average of 11 years of follow-up. The most important is not to compare with fusion, it has already been done, but to publish our evidence that long-term shows it works and the results are still maintained with time. For that, we compare the 1 and 2 levels and prior surgery and no prior surgery. You see the groups, group 1 level, no prior surgery, group 2, 1 level, prior surgery, and you see the volume of patients from 500 for the first group to 250 for the fourth group. The average was the same for 43 years old. What is important is to debunk those preconceived ideas, and we use ODI, visual and neurological scale, and the leg pairs for the leg and back pain scores. You have just to imagine that we started that in 1999, and so we recorded all the results. This concerns more than 50,000 data on Excel table. The ODI improvement was 26 points for all the group. For the worst one, which is the post-discectomy syndrome, only 24 points, but it's very equivalent and with statistical evidence. After that, we wanted to show what is the real result and is there is a difference when patients has been operated before. As a complication or revision, our index level is 0.48%. If we consider the number of implants, and the adjacent level degeneration that requires surgery is only 1.8% to be compared to our results when you fuse people and the evolution of the adjacent level at follow-up. Here is the evolution of the ODI, and with up you can see the gain. The gain is between 26 and 24 points on ODI, but all equivalent at the end. The same for the leg pain, for the back pain, for the VAS, you can see the equivalence and the gain, which is between 3.6 to 4.1, which is very, very narrow difference with a virgin case at the beginning and already operated one with a recurrent disc herniation. So there is a good salvage of the procedures for that. The same for the leg pain. Here you can see these 2 levels with the 2 levels and disc, and you see the quality of the result long term. And I insist on that. You see here the pelvic floor is 33 degrees in pre-op. Don't focus only on the levels operated on. And we can look at the global motion of L1 is 63 in pre-op. After that, you look to the control after years, and you have 47 degrees of pelvic floor. That means 14 degrees of improvement. And If you go directly to the L1 race, you are 97%, 97 degrees for pre-op of 60. That means that your gain in the total motion is always superior to the local gain at the index levels. That means that restoring the motion, you gain for the pain, you gain for the ODI, you gain for the function, and you gain for the mobility even more than your local gain. There is an influence on the changing the disc to the global motion of the spine. That is why it's so successful and so positive with our patients. You can find that also on this table, on the quality of the gain and the equivalence in the motion and gain between the different groups. I wanted to thank you and say that will be published this year in GBGS as accepted the paper. Thank you very much.